All right. Hey, Shoshana, question for you. If I were to make you a co-host, would you mind the waiting room for me? Is that something you're comfortable with?
Sure. Happy to
Okay,
do that.
let's do that because once I pop into the slides, it'll be hard for me to keep track of everything. So
Yes.
I'm going to go ahead into participants. I'm going to go to you, and I'm going to uh, make you a co-host. So you should be able to um, unmute or go into the waiting room.
You,
Are we good there?
yep,
Okay, cool.
got it.
Perfect. All righty. Okay. There we are. I'm going to say a special hello to Kristen Ocean. Nice to see you here. So anyway, if you feel like opening up your screen and being on camera, great. And I totally am fine with people preferring not to do that. I'm sure it's lunchtime in many places and people might be busy eating right now. So I'll go ahead and get started. I'm Allison Schreier, and I, just by way of introduction, am with Zinnia TV, and we host these monthly sessions, caregiver education and support. And we do that because of my experience as a dementia family caregiver for my husband, who had frontotemporal dementia, a support person for my parents, who were each married to a person who wound up getting one or another form of dementia. And I worked for quite a few years as a dementia educator in classrooms that were located in long-term care communities where I was teaching full-day dementia education. And then I also spent some time at the University of Washington, 3 years, where I launched and helped manage a program that was all about education, but in this case, the students were primary care providers. And so I recognized for myself that education was absolutely the key to my being able to understand how to be with and support my husband and others who are living with dementia. So today's topic is about sexuality, intimacy, sexualized behavior. And the reason that I wanted to discuss this is because I think it's a big issue that often people are reluctant to talk about. I know that even when I was in a support group with other caregivers, we often danced around things. And then every now and then a conversation would start where people would say, "Oh my God, you too?" And we'd sort of like, it's so good to talk about this, but it's so hard to talk about. So I invite you to share as you see fit or not if you would rather not. And it was especially my work in a long-term care setting that helped me to understand just how big some of these issues can be and how misunderstanding gets in the way and so on. So I'm going to be talking from the perspective of family caregivers, but I'm also going to talk about the situation in long-term care because some of you might be people who work in long-term care. Some of you might have family members who someday live in long-term care. And so it's good to be aware of the unique issues that arise in those places. So I have the recording going. I've got Shoshana manning the waiting room, and I'm going to go ahead and share my screen. And let me play from the start. So if somebody could give me a thumbs up that you see just the screen that has Zinnia and then the title. Okay, great. Thank you. So,
Allison, actually, we can see your. Oh, probably because I'm co-host. Never mind.
okay,
Never
all
mind.
right.
No, no, everyone can see the behind the scenes, the
Ah,
presenter mode.
okay.
Oh, you can see my presenter mode.
Yes, we
So
can.
let me see if I can, um, let me just try some magic for a second. Do you still see my notes?
We are good now.
Okay, great. So I'm going to make my mouse go someplace else. Go away. There we are. Okay, I think I'm good to go. Thank you, everybody, for your patience. So our learning objectives today, we want to talk about the importance of intimacy. We'll talk about sexuality changes that are associated both with aging and with dementia, because there is some crossover there. We'll talk about something called ISB, inappropriate sexual behaviors, as well as how to manage those behaviors. We'll talk about something which I don't have on the bulleted list, which is called sexualized behaviors, so things that might be interpreted as sexual behaviors but actually aren't. We'll talk about the implications of these things in long-term care. And then when we're finished with this conversation, I invite any questions that you may have about this topic or about anything. So first, to talk about intimacy. So we as human beings are born with a craving for human touch. And that is something that starts from the time that we're born. I know that when my own sons were born, the first instinct was to put them on my bare chest. And that skin-to-skin contact is just something that we are conditioned to, and that soothes us and brings us peaceful feelings from very, very early on. And it doesn't have to be skin-to-skin touch. Human touch, even rubbing someone's shoulders, rubbing hands. I rub my own hands. I rub my own feet. Human touch activates the parasympathetic nervous system. It helps us calm down, lowering the heart rate, lowering the blood pressure. Anxiety and stress are reduced, and we get this feeling of being safe. And this is something that never goes away. The Gottman Institute, which some of you may be familiar with, they have all kinds of programs to support successful, loving relationships. Talk about the 3-breath hug. And that being that I wrap my arms around a person like we see in the picture there, and we very slowly together breathe in and out 3 times. It does amazing things to foster intimacy and to lower our cortisol, which is our stress hormone. Skin-to-skin time. After I had read about this, I suggested this to my partner. He thought it was a great idea. But what the Gottmans talk about is, even just not sexually, just having our skin touch, if it's our tops, if it's our arms, if it's just our hands, just that skin-to-skin connection does something really special to help us feel loved, to help us feel safe, respected, all of those things. So intimacy, we never lose it, a need for it. So sexuality and aging, well, according to the NIH, aging can result in the best sex ever. Many older couples continue to want and to derive a lot of satisfaction from sexual intimacy. This, despite the fact that it completely creeps out anybody under the age of 30, I think it's completely normal for us to continue to want sex. We have fewer distractions. For a lot of us, we have more time available to really relax and spend loving time together. Fewer chances that somebody's going to walk into the room and say, "When am I having breakfast?" No pregnancy worries generally once we get older. And I think that as we get older, we become more in touch with what we need, with what we want, and we're better able to ask for it. We're also better able to listen to what our partner wants and be willing to explore with them. But of course, we all know that aging can also impact our sexuality in negative ways. So physical ailments and medications, right? Oh, that shoulder, I can't really push myself up anymore. My heart makes it really difficult for me to exert myself. That's real stuff. Unresolved relationship issues. I would say that for myself personally, the people in my life who are open about the fact that they are no longer sexual with their partners oftentimes are actually in a relationship that's not a very loving relationship. where there are issues that probably should have been dealt with long ago, and now they've just kind of pushed it aside. They don't have sex, and that's that. Stress and worry as we age, because boy, there's a lot to cause those things. Financial issues, perhaps. And again, the health issues that we already talked about. Feeling less attractive. So my partner and I joke that the last thing to come off when we are going to make love is our eyeglasses, because God, we look so good and we look so young. We joke that when we get cataract surgery, we're going to need to smear our eyeballs with Vaseline before we have sex. But there are also changes to the body that make it more difficult to enjoy intercourse. So for women who have experienced less natural lubrication, the vagina can shorten and can tighten. For men, difficulty getting and maintaining an erection, like this stuff gets in the way. And so, but it doesn't mean that we can't work around those things and find ways to have wonderful, enjoyable sexual intimacy with our partners. So now let's skip over to the idea of sexuality and dementia, which generally involves older people. So the description here of sexuality being something that is a mutually voluntary activity with another person that involves sexual contact, whether or not there is an orgasm. It doesn't necessarily mean that there's intercourse. So a dementia diagnosis doesn't necessarily mean that a person is no longer interested in or is no longer able to perform in a sexual way. So there's this, one of the research studies that I looked at in preparation for this conversation today cited these statistics, that in a study that at 3 years from onset, 46% of the couples still practiced sexual intercourse, and then that tended to go down over time. Now, I will say that there is a dearth of research on this topic. There are a lot of scoping reviews that tie together other reviews that have happened, but many of the research papers that I read drew the conclusion at the end that there is a lot of room for more research in this area. So, let me see, I think if I go like this, there we go. So here's what this makes me think, though, when I look at statistics like this. If 46% of people 3 years out are still practicing intercourse, it means that 54% are not. So there are a lot of people for whom sexual intercourse, sexual activity with a partner tends to fade away when they have dementia. So let's talk about that. So there's two people involved here. There is the person living with dementia and there is the caregiver. So first of all, that study that I just showed you talked about 3 years out, 5 years out, 7 years out. Well, we're still aging, right? So all of the same things that we already talked about with a healthy couple who is experiencing normal aging, there are things that could get in the way that make it more difficult for a couple with dementia to have normal sexual relations. But there are other things, one of those being apathy. As dementia progresses, people tend to just not be as interested in things. That's one of the things that some caregivers report that they first noticed is he just stopped, or she just stopped wanting to do the things that they loved to do. Now, if it's something like, boy, we used to take walks every day and now she really doesn't want to go for walks, well, we might be able to coerce them into a walk, right? Maybe we can say, hey, why don't we walk to the coffee shop? Why don't we drive to the park and walk around the lake? How about if I take this little bag of M&Ms with us and every 10 steps we eat an M&M, whatever it is, which is fine when going for a walk, but coercion when it comes to sex is probably not okay. Medications. Many people who are living with dementia are taking medications like anxiety and depression medications that can actually lower libido and lower the ability to perform sexually. People living with dementia might have confusion or memory loss. So we're not really sure who you are or what our relationship is about because I don't really have the memories that would remind me of those things. So many times I hear people talk about, like, I went to bed last night, my husband called the police because there was a strange woman in the bed, but it was me. They have difficulty sequencing when a person is living with dementia. And we think of sequencing as obviously a step of events towards an end, right? Like a recipe. I know that first I cream the butter and the sugar and then I add the eggs. Well, for many people, there's also sequencing involved in sexual activity. A lot of couples have like the thing we start with and then where we go from there and then we go from there. And that sequencing can become confusing and a person can get lost in it. And then there are constant reminders and then they're not doing well enough. And so it can lead to lots of different issues. Distractibility and boredom. I have very vivid memories in my own life with my husband of sexual activity beginning, and within minutes he would say, "This is really boring," and we would stop. And I'd be like, "It was boring for you." I was okay with it. But anyway, yeah, distractibility and boredom can be an issue. There are changes to the autonomic nervous system that occur that can disrupt sleep. And we all know that when we aren't getting enough sleep, we are less likely to be engaged in anything. And then there can also be a lack of sensitivity to the needs of the partner. So that was fine for me. I'm done. See you later. For the caregiver, there are also issues. So all of these age-related changes still apply to the caregiver as well. And it was my husband's doctor who put me on anti-anxiety meds. And they absolutely had an impact on my own libido. There can be a very strong fear of initiating because I don't even know how aware he or she is. Like, do they want this? Or because sometimes I find out that if I say, like, do you want dinner? And they say yes, but it turns out they're not actually hungry, but they're just used to saying yes to that question. So are they actually interested in having a sexual experience with me right now? We might have lost our attraction to a person. And this goes both ways, by the way. I know a lot of family caregivers talk about, oh my gosh, trying to get him into the shower, right? Trying to get him to shave, trying to get her to wash up her private parts. I'm not sure I really want to go there. He or she is just not themselves anymore. I don't even feel like I'm making love with my partner. It's like it's a different person. And also because of my role as a caregiver, I am feeling more like a parent than a spouse. And it just feels a little like inappropriate that we're still having sexual relationships, sexual relations. Lack of sensitivity to my needs. Like the person, my partner just doesn't seem to really get that I am a living, breathing human being who's a part of this process. Caregivers of partners, that little quote at the bottom, who've been diagnosed with a severe degree of Alzheimer's disease, we can plug in other dementias, report a higher total burden score, and caregivers with higher burden scores have less sexual intercourse. Right, because I'm feeling completely stressed out and sex is just not something that's really high on my mind. I also do want to just bring up the concept of obligatory sex. There was a research paper I read that was all about how obligatory sex impacts the person who's living with dementia. Like I'm feeling apathy, I'm feeling like I'm less than myself, I don't like the way that I am, and I don't really want to have sexual intercourse or any kind of sexual activity with my partner, but I kind of feel like I should because like we're married and I feel like I'm letting him or her down if I don't. And I know that that's true for the caregiver as well, that I am so not interested in this, but I know how happy it makes him or her, and so I'm going to do it. And as we all know, that is also something that can be kind of crushing and stressful. And it happens. And I'm just raising the awareness that that is something that happens, and it's something that we need to think about, whether or not that actually benefits people. Okay, moving on from here. Oh, the other thing I wanted to say about not being attracted, so I talked about it from the caregiver perspective, but for the person who's living with dementia, who is that old woman in my bed, right? My wife is like 35 and hot, and now there's this old woman in my bed, and I'm not sure I really want to have sex with her. It's a thing. So when there is a misalignment, so now what I'm switching to is the idea that, excuse me, it may be that one person is interested in sex and the other person isn't. As the caregiver, we want to avoid outright refusals and arguments, although it depends upon the person. There's somebody who I was speaking with quite recently who talked about the fact that her husband would often initiate sex in the middle of the night, and she would just say to him, I'm really sorry, but in order to take the best care possible of you, I really need my sleep. And he would just say, okay, and it was over. So if we can still have conversations like, hey, it's not really working for me right now, that's the best, right? I know that in my household, there's an agreement that neither of us should ever engage in a sexual activity with the other if we're just not really into it. So better to be honest and say, that's just not where I am. Now, the person with dementia may not be able to take that information in a non-confrontatory way. So in the interest of avoiding outright arguments and refusals, we might want to reflect and validate. And that could be that I say, oh, sweetie, I love it when you touch my arm like that. I really enjoy it. And I know that you'd actually like it to move into something else, but I just can't really go there right now. And but I do know how important it is to you. And I'd be happy if we pick this up another time. Maybe it'll work, maybe it won't. We'll talk in a little bit about what happens when people get angry and aggressive about this kind of response. That we can distract and offer alternatives of high value. So when my partner maybe approaches me in the middle of the day and says, I would really like it if we could be sexual right now, and it is not something that I am interested in, maybe it's a request that is made all the time. Maybe we just had sex last night. Maybe they have memory issues and they don't remember that we just had sex last night. Maybe I'm just not feeling it, that what I might do instead is say, I get that you are so interested in us going up and having some playtime, and I would love to start it with a foot rub. I got this special oil, and I'm going to rub your feet. And let's just start with that. And so there's the possibility that if I rub their feet, maybe if I rub their hands, that maybe we can move in another direction. Or maybe what it could be is like, you know what, my muscles are just really, really tight right now. I don't really feel like I can go there, but maybe if we go for a walk around the block, that will help me. And then maybe that can be the thing that leads us to not having sex right now if that's not where I want to be. And what research has shown is that an overall increase in non-sexual physical intimacy can reduce requests for sexual intimacy. So maybe we start getting into the habit of every night before we go to bed, I rub your feet and legs and I rub your back. Maybe we do a lot more hand-holding. Hand-holding is intimacy. Maybe when we drive places, I really remind myself to reach out and put my hand on your thigh when you're in the passenger seat. So I'm touching you throughout the day. I walk up behind you and I just rub your neck a little bit. We want to focus on the unmet emotional need. So if we are not going to be engaging in sex, which our partner is wishing we would, it's important to say, I don't want you to think at all that this means that I don't love you, because my God, I love you to the moon and back. If possible, also increase overall activity, because boredom is a trigger. I got nothing else to do. Why don't we have sex? And then, as mentioned previously, that obligatory sex is stressful for both partners. So I'm going to shift now and move into inappropriate sexual behavior. So inappropriate behavior, also called ISB, as they're describing it here, a behavior marked by apparent loss of control or intimacy seeking that is misplaced, both in social context and towards the wrong person. And it may not be sexual in its form, but even just in its suggestion. hey, honey, why don't we go to whatever? Um, I especially liked that this was a paper published by Dr. Kate DiMedeiros. It was a paper of hers that led to the creation of Zinnia TV. So I loved that kind of full circle thing for me. So it's estimated that in 7 to 25% of cases of people living with dementia, that there is some inappropriate sexual behavior. It could be something that happens once or twice. It could be something that is a pattern that happens all of the time. Frontotemporal dementia is the dementia in which a person that is most likely to result in inappropriate sexual behaviors. And an estimate that I read was that 18% of people who are living with frontotemporal dementia are likely to have exhibit inappropriate sexual behaviors. I would expect it to be more, frankly. Inappropriate sexual behaviors tend to be more physical in men and more verbal in women, but I have seen both. And it absolutely results in increased caregiver burden, trying to manage that. It often results in the use of psychoactive medications because we just can't figure out how to make it stop. Early institutionalization, I just can't live with this anymore. He needs to go, or she needs to go live someplace else. There's also a term called hypersexuality, which can often lead to inappropriate sexual behaviors. And hypersexuality isn't just about having a high libido, like, oh my God, he wants to have sex all the time. It's, as it says here, this sort of persistent, uncontrollable pattern of intense urges and behaviors associated with them. I need to have sex. I want to have sex now. And there is a potential for aggression when a person is denied. And this is the kind of thing that is likely to lead, more likely than other cases, to lead to a consideration of medications to help calm the person. But again, more intimacy can help prevent that tendency to trip into hypersexuality. So someone wanting sex when you don't is not inappropriate sexual behavior, but becoming angry and aggressive about it could fall into the category of inappropriate sexual behavior. And I was thinking about, I don't know if you guys remember that scene from Annie Hall, just talking about wanting sex when you don't. That scene from Annie Hall where the friend says to the guy, so are you guys still having sex? And he's like, hardly ever, like maybe once or twice a week. And then it cuts to Annie having a conversation with her friend, and the friend says, so you guys still having sex? And she's like, constantly. It's like once or twice a week. Yeah, anyway. So what does ISB look like? Okay, so it can pretty well be summed up in that first phrase, the wrong person at the wrong place and the wrong time. So we are rewatching Mad Men right now, and there was a scene at the last episode that we watched. Betty's father has had a stroke, and they're starting to notice that he's sometimes confusing her for her mom. He's sometimes forgetting things, and they're all starting to cope with the fact that, like, wow, as a result of this stroke, Dad is starting to have some brain changes. So there's a scene where they've had dinner. She stands up and she goes to clear her dad's plate, and he reaches up and he squeezes her breast and he says, hey, what do you say we go upstairs? That's a perfect example of inappropriate sexual behavior. It is the wrong person for sure. He thinks it's his wife, but it's his daughter. It is the wrong place, like we're in a dining room filled with people, and the wrong time, like we are just finishing eating dinner. This is not the time when that would happen anyway. And so what's happening here is that there are both judgment and memory issues at place, memory issues that are at play here. I remember entering my husband's long-term care community one time, and there was a gentleman lying prone on the sofa. He was completely dressed. He was just lying there. And there was a woman on top of him with her pants pulled down around her ankles, and she was humping him. And he didn't seem to even notice that she was there. And there was no care staff around. So it was just kind of happening. And I thought, well, now this is a perfect example of wrong person. It's not her husband, wrong place, probably not in the living room where there are lots of people, and probably the wrong time too. So that would be an example of inappropriate sexual behavior. So though I mentioned that it's more frequent in physically in men, women can display inappropriate sexual behaviors as well. Other examples of inappropriate sexual behavior: openly watching pornography or talking about sexual acts. One of the reasons why my husband, I made the decision, because for those of you who know my story, my husband was 47, my kids were 12 and 15 when he was diagnosed. And I would sometimes go to book club, whatever, come back, and he's sitting on the sofa watching pornography, and the kids are like at his feet playing Lego. I thought, oh my God, this is not okay. Or we'd be eating a family dinner, and just like somebody might say, pass the salt, he would look at me across the table and say, I'm horny, we should go upstairs, in front of kids. So it is just complete loss of connection with what is appropriate. Disinhibition, taking off clothes when it's not really appropriate. So let's see, disinhibition could look like masturbating in public places. We were at a family movie at a park, outdoor setting. Lots of parents with their children. Again, as I mentioned, my kids are young. We're on those little low chairs that you bring to the movie so that people can see over your head. And it's partway through the film, and my son, who was sitting on the other side, I was sitting next to my husband, my son was on the other side. And my son said, Mom! And I looked over, and my husband has his penis out and is masturbating at a children's movie in a park. So what do? I threw a blanket over him, and I said, this isn't the right time for that. And then I held his hand so that he would not use it in that way. It's also another form of an inappropriate sexual behavior is unwelcome touching. So reaching out and grabbing people who are not open to that. So those are just some examples. I think you get the picture. Most important thing to remember, it is not their fault. So this diagram is just getting across the idea that there are many parts of the brain that are impacted by dementia, and the impact on those parts of the brain are what cause a person to behave in a way that is wildly inappropriate. So showing here that the frontal lobe, for instance, which is the part of the brain that was most impacted for my husband, can lead to disinhibition, inappropriate sexual behaviors, poor boundaries. The basal ganglia, see where that's pointing to, can have changes that cause obsessive sexual thoughts or compulsive behaviors. The limbic system can affect emotional responses, sexual arousal, memory of past experiences. The hypothalamus can cause disruption or alteration of the libido, arousal, or sexual interest. And in the brain stem, physiological changes are involved in physical sexual arousal and response, whether or not we're able to be aroused or overly aroused or response in a meaningful way. So how do we manage these kinds of sexual behaviors? The first is to get out of judgment. We have to remember that it's not because he or she is a pervert. They would never have done this when they were a healthy person. It's because their brain is changing. I was so fortunate last week to attend the annual conference of the Association for Frontotemporal Dementia, where Dr. Christopher Rhodes from the University of Washington gave an excellent lecture, not about sexuality, but about managing behaviors in general for people with a behavioral variant of frontotemporal dementia, which is what my husband had. And there was a woman who raised her hand at one point, and she said, my husband sometimes says the most horrible things. Recently, he made a very racist comment to a server at a restaurant, and I was absolutely mortified. And people who know us have told me that it's probably because he was always that way. He just had the filters that prevented him from revealing it. Dr. Rhodes, do you think that that is accurate information? Was my husband always a racist? And boy, oh boy, if you knew Dr. Rhodes, you'd be so surprised to hear that he can be ruffled. But he was really, really irritated by that. And he said it is so far from the truth. The brain is changing. Who knows where these things are coming from? It does not reveal that that's what a person always wanted to do. That woman who was on top of the fellow that I talked about, she would be horrified. It doesn't mean that she secretly always had a craving to climb on top of men. So we learn to respond and not react, as I explained with my husband at the movie, rather than, because I've kind of been doing this for a while, and I knew what worked better than other things, rather than saying, oh my God, get your hand off your, right? Or what are you thinking? What are you thinking? There are children around. Take a breath. Whew. And respond, meaning that I take my emotion out of it. I put a blanket on him. I take his hand, and I say, this is not an okay place for that. So we want to gently redirect. This is not the right person, place, or time. It's okay to be firm, but we want to avoid scolding. It's okay to say, as we're checking out at Costco and he reaches his hand inside my shirt and grabs my breast, it's okay for me to say, pull his hand out and say, this is not an okay time for that. And I don't want you doing that. It's never okay to allow ourselves to be sexual victims because we're afraid of telling somebody no. We want to remove the person from the situation. And we want to avoid triggering situations and locations, like maybe the beach where all the young ladies are wearing bikinis is not such a great idea anymore. Maybe accompanying you to the lingerie shop is not such a great idea anymore. So those are extreme examples, but we really need to think about what kind of situations we're putting our person into that could lead to failure. I'm going to shift now and talk a little bit about sexuality and long-term care. So as mentioned, I taught for 4 years in long-term care, where my students were people who were boots on the ground, caregivers. And when we got to this part of the curriculum, I would say, so let me ask you a question. Are people who live in long-term care with dementia allowed to have sex? And there would be sort of like everybody looking at each other. Nobody's quite sure of the answer. And I said, okay, let me give you an example. A man and a woman, they are both residents. They are not married. And they are having sexual intercourse. Is that allowed? And the answer is yes. People who are living with dementia are absolutely still considered to be able to make their own decisions. They're still sexual beings. We'll talk about exceptions to the rule, right? But the general rule is if they are able to say yes, and if they are able to say no, and they are able to practice the right place and the right time, then we, in a long-term care setting, they are allowed to have sex with each other. But what I would find is that in those classes, the students would be all different cultures, religions, all different kinds of backgrounds. And so the question would be, wait a minute, they're not married? Nope, they're not married. Oh, well then no. No, they're not allowed to have sex. So then I might say, okay, so let's say they are married, but they're married to different people. Now are they allowed to have sex? And now some of the students who are like, it's okay that they weren't married, but ooh, they're married? They're actually married to other people and they're having sex with each other? No, not allowed. And the answer is, they are allowed. Okay, what about this? We've got Madeline, who moved into long-term care, memory care. She was previously married to I'm going to say a pastor. She has 6 children, and she is now having a sexual relationship with Barbara. Is that allowed? And all kinds of alarm bells go off in the classroom. Wait a minute, she's not a lesbian. Apparently she is now. Again, it's allowed, right? So what is so important in long-term care is that the caregivers understand that they cannot allow their personal bias, their morality, their cultural and religious beliefs to get in the way of best practices, but it's a thing that happens. Compliance and consent are huge. It is my firm believing that when people move into long-term care, that there should be an assessment that determines whether or not are they a person who does display inappropriate sexual behaviors. And if so, are the other residents going to be at risk? How is the staff going to handle this? What are they going to do when this person is behaving inappropriately? What is the staff told about how to handle sexual situations? I would ask my students, okay, so here's the setting. You walk in to Vicky's room and she's not there. You walk into Philip's room and she's there. And she and Philip are naked and they're in bed together. What do you do? And the answer sometimes is, I say, oh my gosh, excuse me. I am so sorry. And you shut the door and you leave. Because Vicky and Philip are both people who, yes, are living with dementia, but they also are people who are quite conscious. They also, we've seen those two. They sit together on the sofa. He always has his arm around her shoulder. She has her hand on his leg while they're eating. They're both engaged in this. So I definitely, as a long-term care worker, I report it to my management, but I back out of the room. If, on the other hand, Vicky is a woman who is far more progressed in dementia, is nonverbal, and spends much of her time in a wheelchair, and is generally kind of out of it. Maybe she's highly medicated. If I find her in bed with Philip, and Philip is like, kind of top of his game, I'm going to pull them apart. I'm going to get him out of the room. That is sexual predation, and it needs to be reported, and there are no questions about that. So careful monitoring and management. We always need to make sure that everybody is safe and healthy, which means that if there is a couple that we know is engaging in sexual intercourse, we need to make sure that are they able to use a condom? Are they getting tested to make sure that they aren't transmitting sexually transmittable diseases? I have spoken to many people who share that, yeah, but they're old, so it's not like they're going to get pregnant. Why would they need a condom? Management of families is extremely difficult in long-term care settings because the husband lives in assisted living, the wife is in memory care, she's having a sexual relationship with somebody who lives in memory care. The husband, much of the time, will be absolutely adamant that that cannot happen. And no way is anybody going to touch my wife. We need to get her out of here. I'm going to kill the guy. I mean, it really causes some big problems. And it's a big management issue. How do we then keep these two people apart? Right? Like, do we need to constantly monitor them? Because they keep looking for each other. Maybe they're both hypersexual. What do we do about that? It's problematic. I've seen many cases where when that is the situation, one or the other is moved to a different community because they can't manage it. I know that in my case, I felt like, you know what, if there is some nice woman who makes my husband really happy, and he doesn't really, now he didn't have memory issues, but if he had had memory issues and he didn't really remember me, because that's what happens, right? They don't even know they're married. It's not that they're fooling around on their partner. They might not even remember that they're married. But I always thought, if there's somebody who can bring joy into my husband's day, I don't know. I think I might be okay with it. Families are usually brought in when there is a situation that arises, almost always. The family is brought in and it's explained to them what's going on. There was one community that I had a student who worked in this community, and the situation that I told you about, the two women, yeah, in her community, it was two men who were having sexual relations, and one of them was not gay, and his children were outraged. That is not my father. This other man is clearly predating upon my father. We need to get him out of there. This is completely not okay. And yet the staff reported, I don't know, he seems to be pretty into it. The way that they managed it, which I couldn't believe, it was a safety issue because these are two big guys and they all have twin-sized beds. And so there was a great fear that one of them was going to fall out of the bed and get hurt. So they made one of the staff members sit on a chair in the room. Can you believe it? I mean, wow. Okay, so anyway, just saying, there's stuff that goes on. And if I were moving somebody into long-term care, I would want to make sure that they do perform risk assessments to see, is my family member going to be predated upon? Or like, is there anybody who is shown to have these kinds of tendencies? So I already talked about a lot of this, but just to make sure I covered everything. So managing behaviors in long-term care. The two times when issues are the greatest are during bathing and bedtime, and toileting as well. And that kind of makes sense, right? Somebody's private parts are exposed. There's a lovely young lady who's touching them and cleaning them. Like, wow. And so that can easily be misinterpreted as some kind of request for sex. And so sometimes what will happen is that we try to use a caregiver of the same sex. In one of the care communities that I was teaching in, they had one guy who was a caregiver, and he was the guy who bathed all of the guys so that they just wouldn't run into these issues. Sometimes people would do things like have the person wash themselves in their private parts. I am a big fan of aftermarket bidets, so that it makes cleaning of private parts easier and there's less confusion. If somebody is a grabber, they reach out and they grab while they're being bathed, it can be really helpful to give them something to hold on to, whether it's a washcloth or like a little rubber duck or something, so that their hands are busy. Important for everyone, but to not ignore and not giggle. I know a lot of you are family caregivers, but as I said, you might have somebody in long-term care one day, and it would drive me crazy when I would see somebody do something inappropriate, like reach out and pinch the bottom of a caregiver, and she would kind of jump away and giggle and say, stop that. That's not the right response. The right response is that we firmly, without scolding, but very firmly turn and face the person and say, you may never touch me that way. And what we find in long-term care is if there is somebody who is has a tendency to grope, that the caregivers are, when they start working, they're told about this person and they try to avoid that person. And I also always encourage them to be aware of where people are so that we don't invite problems. Like if there's a gentleman sitting behind me in a chair and there's another one in front of me in a chair and I'm going to tie the shoes of the one in front of me, I want to make sure that when I bend over, I'm not inviting the person behind me to smack me on the bum. Distraction redirection are absolutely used in long-term care settings, avoiding overstimulation. Public masturbation is something that happens both at home and in long-term care settings. And again, no scolding. Might be the wrong place or the wrong time, but no scolding. Like, that's disgusting. No judgment. I can't believe you're doing that here. Instead, what we do is we just gently walk over to the person and we say, hey, I have a better spot for you to focus on that. And we take them to a place where it's okay, where they're not going to be bothering other people. Long-term care, we always make sure that we knock before entering bedrooms and then report immediately to management, and that caregivers are, of course, mandatory reporters. I will tell you that one time, this is kind of a funny little story. One time, first let me tell you this. When my husband moved to long-term care, which actually was a very smooth process in our household, but he was packing his bag, and into his bag, he threw some of my lingerie. And I said, why are you bringing my lingerie? And he said, for when you visit. And I said, okay, you better bring that then. So he packed it. So like 6 months, 8 months go by. I show up one day, and one of the caregivers pulls me aside, and she said, I need to share something with you. It's about your husband, and it's sort of sexual in nature. And I'm like, oh man, all right, what is it? And she said, well, this morning I went to wake him up, and he had the covers all pulled up to his chin. And I said, Evan, come on, you need to get out of bed. And he shook his head. And I said, sweetie, you really, like, breakfast is being served, you need to get out of bed. And he did not want to get out of bed. And I said, Evan, I'm going to pull back the covers and you're going to get out of bed. So she pulled back the covers and he was wearing the lingerie. And she said, Evan, what are you doing? And he said, cross-dressing. Yep, the brain does funny things. All right. So when it looks like sexual behavior, but it's not, and we call that sexualized behavior. So time to get curious and stay out of judgment. So one of the things that my husband would do is he would shuffle into the community room in his long-term care community with his pants around his ankles. And the staff came to understand that that was his signal that he needed to use the bathroom. So they would pull his pants up and they would walk him to the bathroom. And that was it. Easy. However, one day there was a younger man who was there visiting his mother. My husband shuffled out with his pants around his ankles, and that man was irate. I cannot believe that there is a sexual predator living with my mother. And they explained to him, well, that's just what he does when he needs to use the bathroom. And the man said, you need to do something about this, or I'm going to go to, I'm going to complain. And so the solution that they arrived at, which is the same solution that is used sometimes for people who tend to fondle themselves a lot, is that they insisted that he wear a onesie with a zipper down the back, which I think is horrible. Why is it horrible? Well, because my gosh, now imagine what happens. He walks out and he knows he needs to pull his pants down because he needs to pee, but his pants won't pull down. His pants won't pull down. He's nonverbal except for swear words. So he starts screaming, and now he's a behavioral issue. And because he keeps wetting his pants, he's switched to briefs. So I do still harbor some resentment, if it's not obvious, about how poorly I believe that this was managed. So it could be that a person who is reaching out and touching is not actually reaching out and touching for sex. They're reaching out because they just need intimacy. And I know so many wonderful caregivers, both at home and in long-term settings, who are really great about doing something like rubbing a person's hands and just leaning in and saying, you are so safe here. Or leaning in and saying, I don't know what we would do if we didn't have you here, because you make my day. Emotional and just touch intimacy. So why else might they be touching themselves if somebody is starting to touch themselves a lot, picking at their pants? It could be that their clothing is uncomfortable. It could be that their clothing is too tight. I've seen so often when people immediately leap to the conclusion that it's about something sexual because they're just kind of like picking at their pants. Well, gosh, maybe they're a person who doesn't like the way the label feels in the back. And I don't know about other people's experiences, but with my husband, he really put on a lot of weight. And then he lost weight. So we were constantly changing pant sizes. And there were times when his pants would be too tight and he would pick at them. It might be that their briefs need changing, or that they're not wearing briefs and that they've had an accident. It may be that they were not terribly well cleaned the last time they had a bowel movement and things are a little itchy. It might be that something hurts and they're trying to rub it because it hurts. So caregivers, whether we are professional or family caregivers, need to get deeply curious and not leap to the conclusion that sexualized behavior is actually sexual behavior. There was a guy named John at a community where I did some volunteer work. And at lunch, they would put out spoons along with whatever other cutlery. And he would sit down at the table and he would reach across this round table and he'd grab every single spoon and he'd pull it over to his place. He'd steal everybody's spoon. And nobody really objected. And then one by one, he would open the front of his pants and he would put all the spoons into his pants. And he'd sit and he'd kind of be moving around a little. It was sort of uncomfortable having all those spoons in his pants. And then one by one, he would take the spoons out. And that was it. What's going on there? I don't know. I don't know. But I can see how if somebody walked in, a family member walks in, and they see this man who is sitting at a table with my mother and he's got his hands in his pants, that's a problem. But we need to ask ourselves, is it? And are we being fair to the person who's living with dementia? So at the end of the day, I think we need to, more than anything, I'm hoping that a takeaway from this time together is about the incredible need for physical, non-sexual, and emotional intimacy, which never goes away. And even people with very advanced stages of dementia can be soothed enormously by just gentle touch. Touch on the face, touching right here between the eyebrows, rubbing a person's head goes such a long way to giving them a better quality of life. That's me and my sweetie celebrating the good, and I will go ahead and stop my share. And there we are. So I went a little bit late, but I will go ahead and ask if anybody has questions, anything you'd like to bring up around this topic. I don't need to run anywhere. I'm happy to stay on for a while. Any thoughts? Was this helpful? All right.
Allison, I bet I'm not the only one who feels uncomfortable having to deal with this. And I saw, and I put in the notes that if it's possible, I would like to use this with my caregiver support group, but to do so, I feel like I'd have to have your note pages rather than just the presentation slides. I don't know if you feel good doing that or not, but
Yeah, you know what? I know, Denise, I see your comment there. I agree. Why not give them a double bed? I would be delighted to share both the recording and the notes. I do think that this is education that should be mandatory in many kinds of group settings. So I would welcome you and encourage you to please share liberally. So I will get this up to YouTube, and I will share the link as well as my slides. Is it okay if I just share a PDF of the slides, or do you need me to put those up on a Google Drive, Stephen?
Google would be better, but PDF, if it's not too much trouble, I can deal with it.
I'll do both.
Okay.
Okay, thank you.
You're easy. See, now that was inappropriate.
Slap. All right, friends. I think that we are done for today. Then thank you for all of the comments in the chat. I had a chance to just go through them. And I agree that a onesie would be considered a restraint. I think it's a horrible, horrible thing to do to a human. Oy. That is, I'm just quickly chatting, making sure there's no questions. I think that's it. Got it. I see the links. All right, everybody. If you registered, you will be receiving the recording and all of the notes we talked about. Thank you, and go out there and have an amazing day. Bye, everybody.